Are in shoulder dystocia, pitfalls, guidelines, and ethics. And I'd like to just introduce Dr. Acker briefly. He's asked me to keep it brief. We will go to the next slide, and you'll see his picture. Dr. Acker has had more than 35 years of experience, was the immediate past chief of OB at Brigham and Women's Hospital. And he has been involved in and has been passionate about OB patient safety throughout his career. He is also a much sought-after reviewer for OB cases, and he brings his extensive practical, clinical, and professional liability knowledge of this topic to the webinar today. And so without further ado, I'd like to introduce Dr. Acker. And David, you're on.
Thank you, Peggy. Okay.
Here we go.
Here is, first of all, good afternoon or good morning, depending on which time zone everyone is in. Let me introduce the problem. Almost without warning, in most cases, the fetus delivers just as frequently spontaneously as with instruments, and the head is out, but usually in shoulder dystocia cases, the anterior shoulder is impacted superior to the pubic symphysis. The normal mechanism of the entry of the shoulders into the inlet of the pelvis is in the oblique diameter. In this particular case, it's in the anterior-posterior diameter, and there is not enough room. Fortunately, the posterior shoulder almost always negotiates the sacral promontory and can be found or felt in the hollow of the sacrum. This is an emergency. The umbilical cord is often snugly around the fetus. Asphyxia will occur. If this problem is not resolved within minutes, it's an emergency, and it is an infrequently occurring emergency. And yet, the obstetrician or midwife must take control first of him or herself, then not really controlling other people in the room, but organizing the team to help. There has to be quick thinking, planning, calmly calling for help from another obstetrician, pediatrician, and anesthesiologist. How can you actually keep control in an emergency situation that occurs infrequently? The answer is there must be simulation and drills for this emergency. A midwife or a doctor can go years with an average practice and never have this happen to her or him. And the only way to stay calm and do the right thing is to practice this. And the only way to practice is with simulation and drills. This is a quick review of the anatomy of the trunk of the brachial plexus. It involves the coming together of 5 nerve roots from C5, cervical 5, to thoracic 1. For the most part, when there is a shoulder dystocia, no damage to the nerves occurs. When damage occurs, it is often stretching of the nerves, and in, let's say, 85 to 90% of cases, the upper extremity weakness resolves, and there is no residual. In a small percent of the cases, these nerve roots have been torn, and they will not heal. Surgery will be necessary. This is a picture of the end the upper extremity that is served by the different nerve roots. Okay, let's start with definitions. The good news about definitions is they are arbitrary and they are standardized, and as you can see, it avoids the problems up there in the top almost definition of the opinions of many. It is not that I think 4,000 grams is macrosomia, or you think it should be 4,500, or someone else thinks it should be 5,000. Down there in the bottom in red, I have the American College of OB-GYN definition of macrosomia, whether you are the infant of a diabetic gravida or the infant of a non-diabetic gravida. It's the same number. The American College, when this definition was promulgated, assumed clinicians would know there actually are differences between infants of diabetics and infants of non-diabetic gravidas, and that different responses can be offered to women whose estimated fetal weight is approaching 4,500 grams and non-diabetic or diabetic gravida. The reference is in the bottom left part of the slide. This is the number we're going to use in this discussion. 4,500 grams true birth weight. Estimated fetal weight is what clinicians have to deal with. Let's start with informed consent. And I want to be quite clear. That piece of paper that we ask the patients to sign before we do this or before we do that, that's called a consent for a procedure. It is not informed consent. Informed consent is not a one-shot sign here type experience. It's a process. It's part of the ongoing clinician-patient relationship, which frees the patient from coercion, manipulation, infringement on her body and her integrity, and gives her the privilege or right to make choices that will affect her health and her unborn baby's health. And it causes active participation of the patient in her own care. It could and should be going on during the entire pregnancy. And again, it is not that piece of paper. Well, we all probably think we're doing this well. But let's say an outside observer is asked to judge how well we give informed consent to a patient. The top three bullets here have stood the test of time as far as I'm concerned. Consistent with common practice, meets the reasonable needs of the ordinary person, and at the same time addresses the unique needs of an individual patient. There was a time when consistent with the golden rule was added to judging the adequacy of informed consent. And for those who may or may not know this, you can almost go to any religion on the planet of the earth and you will find some variation of the golden rule. In some religions, it's do unto others as you would have others do unto you. In others, it is do not do unto others what you would not want people to do to you. The trouble with this, with giving informed consent, it sort of sets the doctor or the midwife as the standard. And that's not what this is about. The woman is the standard, as unique as she is. So I would drop out bullet number 4 and concentrate on the top 3 bullets. So, what do you tell someone? For infants with a true birth weight who are delivered vaginally, the likelihood of a permanent paralysis, permanent Erb's palsy, is 1 in 1,000. So let's, for the moment, dissect that statement. Because no obstetrician or midwife knows what the true birth weight is. We deal with estimated fetal weight. And after 35 years of delivering babies, I would candidly tell my patients I am never more than 2.5 pounds off on my estimated fetal weight. And that's after 35 years of practice. Therefore, we deal with estimated fetal weight. And we have to recognize we can be undercalling it and overcalling it. Nonetheless, when macrosomic estimated fetal weight is discerned either by physical exam or by ultrasound, and both have about the same error rate, it would seem to me that the complete absence of a pre-delivery discussion, especially if it's coupled with the subsequent tragedy, but even if it's not, the complete absence of a pre-delivery discussion does not meet the standard of care and does not comport with informed consent. On the other hand, how one does this, who does it, when one does it, is not the type of thing that can be advice given from on high. Individual professionals have their own way of talking to their own individual patients. And it would be completely arrogant of me to be telling anyone how or what to say. However, as I just said, it would be completely arrogant of me to be telling someone how or what to say. So now let me take a step back from that and quote my wife, who, after only 47 years of marriage, seems to feel that that phrase at the top of this slide still pertains to me. And she will often say, David, it's not what you say, it's how you say it. So let's talk about 2 different ways of saying things. You can estimate that the risk of a shoulder dystocia is 10%. And if you say that in a frightening enough manner, every woman will opt for a C-section. You can actually scare anyone into having a C-section. On the other hand, if you say, so-and-so, there's a 90% chance of your not having a shoulder dystocia. I don't actually think that's fooling anyone, but you're saying it in a way, it's still just as truthful. You're saying it in a way that doesn't frighten unnecessarily someone into a C-section. Let's go on. If you have a shoulder dystocia, there is a 7% chance of an immediate Erb's palsy. Or, you have a shoulder dystocia, there's a 93% chance of not having an immediate Erb's palsy. If you have an immediate Erb's, there's a 15% chance it won't be permanent. Or an 85% chance it will resolve. There is a risk of permanent paralysis. And that's the word, paralysis. It's not nerve weakness. It's not damage. There can be paralysis, lifelong, On the other hand, there's a 999 over 1,000 chance no permanent paralysis will occur. I think if all you do is concentrate on the left side of this slide, you might as well book the C-section right now. If all you do is concentrate on the right side, maybe you're making too light of this situation. And probably like so much in life, if we stay in the middle of the slide, on the one hand this, on the other hand that, and give honest numbers, that's about as good a job as I think a person can do. Let me jump. These are, after 35 years again of practicing obstetrics, these are some of the traps I have fallen into, and I have seen my colleagues fall into this. Let's take the first one. I know that the American College sanctions high-dose Pitocin induction, and then augmentation, and low dose. But more than 50 years ago, Dr. Calderón Garcia in Montevideo, Uruguay, documented that as the cervix dilates, less oxytocin is necessary to maintain adequate contractions and normal second-stage labor. It is a rare hospital policy, though, that says when you reach full dilation, cut back the pit by 50%. But in truth, that's what you can do, and the same contractions will continue. Try and avoid high-dose Pitocin in late active labor and in the second stage. Here's the next trap. Rightly so, mothers can be exhausted after a 1, 2, or 3 hour second stage. And the head can be deliverable with instruments. However, the mother can also be encouraged to rest for a half hour, 45 minutes, or an hour, and give her a chance to get over her exhaustion. Beware this ACOG approved indication for instrument delivery. Treat exhaustion with a little bit of rest. Here is my advice. If you are using fundal pressure to bring the head down, bring your checkbook to court because you will lose the case. There is no indication in modern obstetrics for fundal pressure to bring the baby's head down. Next trap. You're standing there and you have patiently waited for the spontaneous delivery, and the woman pushes and the head comes down almost out. Then she stops pushing and the head goes back up. Then she pushes again and the head comes all the way down again. And then she stops pushing, the head comes back up. What do you think you're seeing? You're seeing a shoulder dystocia in the making. The anterior shoulder is not entering the inlet. The head comes down with the push and is pulled back up. So what do? You can reach for that delivery room table, get that scissors and cut that episiotomy, and the head will come out. But the shoulders are still stuck. And you've created the shoulder dystocia. Keep that scissors on the delivery room table. Talk to the nurse, talk to the patient, talk to yourself. But don't try and make things better by cutting the episiotomy then. No progress note. I'll tell you, doctors hate to write progress notes. And the benefit is not documenting for some future infrequent medical legal occurrence. The reason to document in a progress note is you can look back on your thoughts an hour ago or 2 hours ago when you were calm, not so fatigued, not so committed to this or that, and realize what you said and what you planned an hour or two ago, and actually pay attention to yourself. Why else do it? Here's the story. It is uncommon to get a shoulder dystocia. It is uncommon to get an herbs, and it is uncommon for the herbs to be permanent. It is common when it is permanent that you're going to be sued. That's life in America these days. Now, by the time that lawsuit occurs, I can guarantee to you the nurse who was with you has been involved in hundreds of deliveries and has forgotten yours. And you may or may not remember it. This is what I suggest. The American College has just published a treatise on brachial plexus injuries. About 150, 175 pages long, and towards the end, there is a template for a shoulder dystocia delivery form. Buy the treatise, photocopy the template, and use it for deliveries. It'll just take a few minutes to write down what actually happened. And those few minutes, one day, you'll thank yourself for doing it. The other reason, there you are in court, and the nurse has forgotten your delivery. I assure you, she's forgotten. You can hardly remember it. And what you say in court, it is my usual and customary practice to not exert too much force. And you have now fallen into the plaintiff's attorney's trap, because that plaintiff's attorney will look to the people in the jury and say, I never said Dr. So-and-so usually and customarily pulls too hard. But in this case, he or she did. How do I know that? Look at the outcome, the paralyzed baby. And my expert witness says it never happens unless you pull too hard. And the doctor himself or herself can't remember that they didn't pull too hard. Write the delivery note. It will save you grief years later. Here are the elements. Now, I must admit, ACOG has a much more extensive template, and I will defer to them and say, don't waste your time copying my list down. Go to the ACOG treatise and take their list. But basically, you want to know when the head delivered, when the baby delivered, who was there. Ask those people to write down what they saw. Don't just name the maneuvers. One person's McRoberts maneuver is not the same as the other person's McRoberts. Wood screw maneuver can be done counterclockwise or clockwise, from the pressure on the back of the baby to pressure on the clavicle. Describe what you did. Describe how much force you used. Well, how can this be done? No one knows how many pounds per square inch they used. But you can write, I use the same force as I do for a multiparous delivery, as I do for a gravitar 1. Say something. And then check out ACOG's new document for brachial plexus injuries. Now, the baby is injured. First, don't ignore the baby and tell the mother everything is okay, as if you didn't notice that one of the arms is not moving. Okay? It's there. She'll see it very soon, and she will trust you less if you didn't see it or if you didn't talk to her about it. At the moment you discover it, it is perfectly ethical and honest to explain the recovery rate is greater than 85%, and there is therefore a high likelihood of recovery. But don't say something like, everything will be all right. Explain what happened. And contrary to what some people advise, except for saying, I love you, which is not what I'm advising you to say to the patient, there is no more powerful words that two humans can express and hear than saying, I am sorry. Saying I'm sorry is not synonymous with saying I'm guilty. You can be sorry for a lot of things. Their distress at seeing their baby, their fears, their anxiety, the work they're going to have to put in, possibly taking the baby for physical therapy. There's a lot to be sorry for. Link with the patient. If you think about all those times when you deliver an ACOG 9 baby, and actually you didn't do anything, the mother pushed the baby out, really, and everyone thanks you and says you did a great job, and you know that it was the mother who delivered the baby. Here's the patient who needs you. This is not the patient to not see the next day even though you're not on call. This is not the patient to have your nurse give her an appointment for 6 weeks from now and never talk to her. This is a patient who needs you much more than those patients who have ACOG 10 healthy babies. Keep in touch with the patient. And then, take a look at the ACOG practice bulletin from over a decade ago. That will show you that these things can happen regardless of almost anything. It can't be predicted with accuracy. Induction doesn't help or hinder. C-sections are not recommended. The sequence of maneuvers is a fielder's choice. What it should not be a fielder's choice is avoiding simulations, avoiding drills. And I wish you the best of luck with your next patient and hope all goes well.
Well, thank you so much, Dr. Acker. That was great. I just wanted to remind people again that you can ask questions by clicking on the orange box with the right arrow located in the upper right hand of the screen. Type in your question, press send, and we will try to answer as many questions as possible. And thank you so much for your questions. There was one question that came in right at the beginning of the talk, and it was about, are we able to obtain a copy of the slides? And the answer is yes. This will be posted on the OB Consult website so that you can access it most likely tomorrow. I'm pretty sure by tomorrow or later today. I'll just take a minute to see if there are some other questions that are coming in. I have one here also, Dr. Acker. Are there other places that one might find documentation forms that you referred to? Are there other documentation forms that you know about for shoulder dystocia?
Well, I was trying to be modest about this, Peg, but a long time ago I wrote a paper called a Shoulder Dystocia Intervention Form. And it was either in the American Journal of OB-GYN or the other journal, OB-GYN. And so if you use PubMed and just plug in Shoulder Dystocia Intervention Form, you'll get some of my youthful wisdom many years ago. But I wouldn't bypass ACOG's current thing. It's a page-long template, and it's terrific. That's why I didn't mention my own thing during the talk anymore.
You were probably way ahead of your time.
Thank you, Peg. I was way ahead of my time.
I should also mention to the group that OB Consult also has an OB bundle, and it actually encompasses all of the things that Dr. Acker was talking about. The bundle includes a clinical risk assessment tool, which would cover a lot of the information that Dr. Acker mentioned about going over, doing the evaluation with the mom, having the discussion, having the patient acknowledgement, which is another tool, being able to really get the information to her so that she can make an informed decision. The drills, what would go on in drills, and the another shoulder dystocia documentation tool, which will probably be very similar to ACOGs. And then finally, and Dr. Acker mentioned this, and he did spend a lot of time on this, but an adverse event documentation form. So having some of the questions or the words to say or the information that you want to make sure that you cover with the family would be very important. So that's our shoulder dystocia bundle. Just see if there's another question. You mentioned, here's one, you mentioned simulation drills. We don't have a mannequin to use at our hospital, and the doctors are often invited to the training. But if they're busy in the office, they generally don't attend. How do we get them to participate in the drills?
Well, let me be non-diplomatic and blunt. Unless the leadership in the hospital believes in safety, you can give up trying to get them to come in to do it, period. And the leadership will rue the day that they avoided their responsibility by not causing this to be mandatory. Because I can assure you, after the lawsuit comes and the question is asked, did you do any simulation drills? And the doctor says no. Right after that, administration will wake up and cause these things to be mandatory. Whoever asked that question, because my speculation is it was not the president of the hospital, and it was not the chief medical officer who just sent that question in. Those are the people who either believe in safety or are making believe they believe in safety. And if you're in a hospital where they make believe they believe in safety, find a job somewhere else. Because you shouldn't have to be begging the doctors, threatening the doctors, coercing the doctors, or bribing the doctors. I understand that doctors in private practice are busy and they have responsibilities in the office. But I strongly believe that leadership in the hospital either makes believe they believe in safety or believes in it. It's as simple as that. That makes me very unpopular with hospital leadership, by the way, when I speak that way.
Okay, let's just see. I think we have one more. As a childbirth educator, I found that your presentation of the facts to be very refreshing.
Who's that person who wrote that in fact?
How would you suggest that we use this information in our classes with our expectant couples?
That's actually a very good question. I think that the complication of shoulder dystocia is a legitimate educational discussion in childbirth. And I think that introducing it to the patients is legitimate. But I think that it should be coupled with, please consult with your doctor for his or midwife for his or her individual view. So I would start it off and link it.
Good. And I think that may be just about all the questions that we had for today. So I believe we have one final slide, but I wanted to thank everyone for attending today. Thank Dr. Acker for his presentation. And if there are specific other questions that you might have, my email is right at the bottom of this. You're welcome to email me, and I can certainly send it on to Dr. Acker. If you thought of something that came up at the end of this session and you thought maybe you still had time to send in your question, we're happy to handle that. So Dr. Acker, thank you so much, and we look forward to the next webinar, which will be in July. We'll be looking at 6 is the new 4. Dr. Richard Waldman will be doing that webinar, and I hope that you'll join us. Thank you again.
What does that mean, 6 is the new 4?
Oh, the new ACOG with the stages of labor and the changes in early and active labor and second stage.
Oh, well, I'm going to have to join in.
Good. We'll look forward to having you.
See you.